Good morning. My name is Catherine Wall, but I think everybody in here knows me, so good morning, guys. I'm really pleased to introduce Dr. Ann Gramza. She's an oncologist. She's staff clinician in the endocrine oncology branch at the National Cancer Institute at the NIH in Bethesda, Maryland. Her lab research has focused on the molecular genetics of thyroid malignancies, in particular as targets for therapeutic agents. She is I think I just read that. She received her MD from Ohio State University, followed by clinical training in internal medicine and palliative care at the University of New Mexico, and fellowships in hematology and oncology at Oregon Health and Sciences University. Following further work with the Portland Veterans Affairs Medical Center, she joined the staff of the National Cancer Institute in 2010. And I know you've been a speaker with us before, and we're all very glad that you could come back and join us again. So.
Good morning. Thanks for letting me speak again here. I always enjoy my talks here. This one's going to be a little different. I'm trying something new. So I'm going to talk about targeted therapeutics for the treatment of advanced medullary thyroid cancer. And the first thing I want to do, because I feel like I spend a lot of time in my clinic trying to explain what targeted therapy is, and it's hard if you don't have a strong genetics or biology background to really understand what it is. So this year, I'm going to try to help you understand what the title of the talk means, and what do I mean by molecular, what do I mean by targeted therapy. Hopefully this isn't going to be too simplistic. And then understand how this applies to medullary thyroid cancer. Understand the approved targeted treatments for medullary thyroid cancer, and learn what may be on the horizon. So what do I mean by molecular? I think one of the things that people don't remember or you never learned is how the DNA becomes proteins. And it's these abnormal proteins that cause the cancer and so that drive the cancer. So I'm going to try to show a short video that I think is really good. Yeah.
The lights are funny. It's hard to see the screen from here.
Oh.
I was wondering if it'd be possible to turn a light down. I'm sorry to interrupt.
Oh, no, that's okay. Okay, well, apparently I can't show it. That's okay. Next time.
Thank you.
This video was great, and it showed the basis of molecular genetics, but instead, I'll just go to my slides. So what is a gene? You have cells in your body, 50 million cells, all different kinds of cells. Everywhere there are cells. And in the cells, you have the nucleus. And in the nucleus are all of the chromosomes that you're born with. So you have 46 chromosomes, 23 pairs of chromosomes, one from your mom, one from your dad. And 22 of them are the ones that encode these certain traits, and then one is an X and Y if you're male, and one is an X and X if you're female. And within these chromosomes are strands of very tightly coiled DNA. And the DNA is made of these nucleotides. There are only 4 of them, T, C, G, and A. So 4 nucleotides in different sequences are sort of like a code that your body follows to give you all of the traits that you have. And so how do these genes make proteins? Well, you have the Ret gene here, trying to use the microphone and the mouse at the same time. So you have these the Ret gene here. So the gene is just a section of the DNA that has a specific code on it. And the RNA comes in and it makes a copy of the code. And then there's this sort of machine that takes the RNA, which is the copy of the code of your DNA, and it makes it into this protein. And the protein is just a series of amino acids. And each amino acid is just 3 nucleotides of the code. So that's sort of an overview, and then you get the protein. So sorry. So what is a mutation? Well, if you look at the DNA, oh my goodness. So if you look at, oh my God, I'm having technical issues, sorry. So if you look at the DNA, this is to say a normal gene, and in this code you have a T, C on this side, and it matches up with the A, G on this side. All a mutation is if this A turns into a C. And that's all it takes to start a cancer. Just one little mutation like that in all the DNA that you have. So a lot of you have heard about the Ret M918t mutation, and I'm just going to explain quickly what that is. So you have your DNA. This is the codon 19. So this is the section of the gene for Ret that makes Ret protein, and it's one of the sections, and it's just one little part, 918, and there's an A, T, and G. And that A, T, and G is the secret code for an amino acid called methionine. And so when you have your normal Ret protein, in this spot you have the methionine. Well, what if that T changes? If that T changes to a C, that's all that has to happen, then that secret code is for threonine. And then you have a mutant Ret protein. You have a threonine instead of methionine, and that's all that M918T is. It's just a substitution of one nucleotide that makes a different amino acid and causes all the problems. So here's just a bigger picture of the Ret gene and the protein that's made. So this is the protein, and here you can see all the different areas of the mutations and then what happens, what the protein does, and as we know, when it's deranged, it causes medullary thyroid cancer. So there are mutations in about 30 to 50% of sporadic medullary thyroid cancer, which makes up about 75% of all medullary thyroid cancer, much more common than hereditary. And there are mutations in nearly 100% of hereditary medullary thyroid cancer, which makes up about 25% of the cases. So what does this mean? What are these different kinds of mutations? Well, in sporadic medullary thyroid cancer, you have somatic mutations. And somatic mutations mean that it only occurs right where the tumor is. So you can't pass them on to your children. They're non-heritable. And in this example, they show the breast tumor. I really need to figure out how to make this pointer work. Maybe it's not a pointer. I either need to figure out how to make the mouse work or the pointer work. Okay, so it's just in the breast tumor, and that's what sporadic medullary thyroid cancer is, except it's in the thyroid. And then familial medullary thyroid cancer, or MEN2, is where you have what are called germline mutations, and those are present in the egg or sperm. So those are inheritable, and they cause the cancer family syndromes, and here they show it in the ovary. So this mutation is in every cell in your body. And your children, if it's passed on, will also have it. So what is targeted therapy? Well, targeted therapy is designed to interact with molecules that are parts of the pathways used by these cancer cells to grow, divide, and spread through the body. And they are supposed to disrupt the cancer processes with precision. So what makes a good target? Well, the best target is a molecule or pathway that's present in cancer cells but absent in normal cells. So, you have a target, you can go after it, and it will only attack the cancer cells and not normal cells. So a really good example of this, a very simple example that most people know about, is Tamoxifen for breast cancer. And that's because breast cancer cells, breast tissue, uterine tissue, there are some other places, have estrogen receptors on them and in the nucleus. And what tamoxifen does is it binds to the estrogen receptor and then blocks the further activities of what estrogen would do if it was able to bind to the estrogen receptor. So that's why it's a good treatment for breast cancer. So what are different types of targeted therapies? They're made up of small molecules, which are the ones that are approved by the FDA for advanced medullary thyroid cancer. They're also antibodies, which haven't really been successful in this treatment of this cancer, and vaccines. So we'll start by talking about small molecules. So small molecules can travel into the cells, and they interfere with specific areas of the target protein to block the protein's activity and prevent it from acting or interacting with other proteins. So vandetanib, for instance, will go into the cell and block the abnormal Ret protein. And what proteins do we have that we can target in medullary thyroid cancer? Well, like I mentioned, the proteins with mutations, because the mutations in the DNA, like I talked about, cause mutations in the protein, and then these mutations in the protein turn on all of these processes that cause the cancer to grow, and they just don't stop. And so if you can find a drug that can target that protein, then you can stop the cancer from growing, hopefully cause the cancer to shrink. So Ret is the one that we've been trying to target. Also potentially Rash, which is another protein. And then proteins that are important for thyroid cancer survival, growth, and spread. So other receptors on these cancer cells like VEGFR and EGFR. And this is just a picture of, say, Ret and the different proteins that we could maybe block to cause disruption of these pathways that make the cancer grow. So what's the progress? Well, as you probably all know, vandetanib and cabozantinib are both approved for the treatment of advanced medullary thyroid cancer. So the question is when should patients get treated? And which one is better? And which one should be used first? And which one has worse side effects? These are the questions that everyone wants to know the answers to. So I'm going to try to answer them, but first I'm going to give you a little mini tutorial on clinical trials, because you hear all of these things like there was a 45% response rate in medullary thyroid cancer patients on vandetanib. Well, what does that mean? I mean, what does that mean? And then you hear, well, the progression-free survival was this number of months. What do these things mean? They're very specific terms that we use that are sort of misleading to people, I think. So when we look for a response, when we look for tumor shrinkage, we're picking areas of the cancer on the CAT scan and then measuring them at the biggest points and adding those measurements together. So you'll pick if there's a really easy to see spot on the liver or a spot on the lung, the spot in the neck, and you pick you kind of pick a couple representative spots and you measure their longest diameter and add that together. And then if there's a decrease in the total measurement by at least 30%, that's considered a partial response or a PR. So it has to shrink by 30%, which doesn't really sound like a lot, but that's what we consider a response to be. A complete response is obviously if everything goes away. Yeah, so it depends on the clinical trial. So usually, you'll have to have, you get treated, then you have your imaging studies, your CAT scan. It's usually a couple of months, 2 to 3 months. And then you have to have a repeated imaging at least 4 weeks after that shows the same result. And then that is considered a response. So you can have a response, you could have a response right away, but it would have to be confirmed 4 weeks later. So it just depends on the way the study is written. So then what is progression? I have to say, I'm sorry, your cancer has progressed. And what does that mean? Because it sounds really bad, usually because people have to come off of the drug. But it actually is only an increase of 20% in the total measurement. So it can just be a matter of millimeters, depending on how much cancer we can measure. And that's what we call progression, or PD, progressive disease. And then stable disease, yeah.
Is progression always just imageable, or is it like with medullary medullary, we have the calcitonin and CEA numbers that we're also focused on.
Right. So in the clinical, so the question is the disease, is progression always measurable on the imaging studies, or do we sometimes use calcitonin or CEA, the tumor markers? The answer is, in clinical trials, we go by imaging. So we go by what we can see on CAT scans, and that's because that's how all of oncology has done it in the past. And we look at calcitonin and CEA, but we don't use those as endpoints, so we won't change management based on that. There's let's say prostate cancer where people focus on PSA. Sometimes there are clinical trials that look at the increase in PSA, and that's the endpoint for that study, and that could be progression on that study. But usually when you're talking about most cancers, and it could be in the future, that's what we're going to do with medullary thyroid cancer when our treatments get better, when we can actually, have someone who, just had surgery and has a calcitonin that's still detectable on the blood test, and we give them a treatment and we see if we can keep the calcitonin low or make it go away, because we don't have anything to measure. So it depends on the study. Right now, it's usually on the imaging. Yes?
All right, so you talked about response. They take representative tumors from everywhere else and basically add the values together.
Yeah.
And they do the same thing with progression.
Yeah.
They're adding all. Okay, so if they do that, what if you have metastases to the lungs, but you also have lymph nodes?
Mm-hmm.
Do they take tumors that are from different places and add those together?
Yes.
So then the follow-up question is, how do they account for maybe response in the lungs, Van-Etten's working, but lymph nodes in the neck are getting much larger? It could theoretically be progression, but not progression in the place where you're really wanting to fight the disease. So how do they account for those in the study?
So that's a really good question. So the question is if you're measuring spots in different places and one area grows in the lymph nodes, say, and one is stable or has gotten smaller in the lungs. That happens actually quite a bit. And so when we start the study, we pick these specific target lesions that we follow. And usually, if one responds, the other respond, and if one progresses, the other progresses. But I had a patient who had a lot of disease, and he responded most places, and then it stayed stable. Then he had one spot on one of his ribs, and it just kept growing and growing and growing and growing. So, what do you do in that situation? Because you think he's getting overall benefit from it. Well, in that case, you write into your protocol, you can keep someone on the study even if they've progressed, if the doctor, the investigator, and maybe someone else corroborates that the patient is getting benefit from the drug. So I've left people on the drugs after they've progressed quite a few times, especially when there aren't any great options to move to next. So yes, in certain cases, at that point, when someone has progression by these criteria, we would stop following them for response, but you can sometimes keep people on the drug and keep people on the study. And so stable disease, I think, is the craziest part of our measurements, because stable to everybody in the real world thinks it means that nothing has changed. So it's just stable, stays the same. But what it actually means is it can decrease by up to 29%, so it's decreasing in size but hasn't met that 30 mark, or it could be increasing in size but hasn't met that 20 mark, or it can stay the same. So you can look at a drug study and say there's a really low response rate. That means that maybe 10%, 20% of patients had that shrinkage at 30%. But then you can look at all the other patients and see, well, the rest of them had between 10 and 20% shrinkage, but they're considered stable disease. So stable disease can be a really good thing, particularly if it's prolonged. I've had a patient on, we had this vandetanib bortezomib trial at the NIH. I've had a patient on that for, I guess, 4 years, and he's had stable disease the entire time. He never actually had a response. So he did have some shrinkage of the cancer, but you know, he's doing great. So stable disease is sometimes a really good thing. And then what about progression-free survival? Because you know, in medullary thyroid cancer, other thyroid cancers, usually they're really slow growing. And so looking at overall survival, meaning the lifespan of the patient, does this drug make the patient live longer versus no treatment? We don't really do that because you have to follow the patients for years and years and years. We are going to have that data eventually for vandetanib and cabezantinib, but that's going to be way, way, way down the road. So sort of a surrogate is what is called progression-free survival. And that's all that is how much time has passed before the cancer progressed. So, and that's, again, progressed by our criteria, the increase of 20% or more. So, and they add the survival in there because the patient obviously has to be alive. And so that's what progression-free survival is. It's just that interval of time from when you take the drug and then you get treated, the cancer stays stable or responds, and then you hit that time of progression. So that's a good number to follow. So I have an exercise. I don't know if you can see these numbers, but here is an example of 3 tumors, 3 sites of metastases, 5, 3, and 2. So the total size of everything I would call 10. So the tumor measurement's 10, and then you get some treatment, and it goes down to 4, 2, and 1. So now we're at 7. So that's considered a response. These aren't to scale, but I mean, they are kind of close. That's, you know, when you're trying to explain to people what response is and you look at this, that doesn't really look all that impressive, but that's what we consider response. And then this one, you get treated for a while, and it's 7, 3, and 2. So only one of the spots grew by 2. In our case, it's usually 2 centimeters, but it can be 2 millimeters. It just depends. And so that is considered progression because now we're up to 12, and that's 20% growth. So I have to do a lot of math. So like I said, the response would be 7 or less in this case, and the progression would be 12 or more, and then stable disease could be anywhere between 7.1 and 11.9. So I don't know if this is helpful to any of you, but I think this is what I get asked about all the time. Yes?
So when you do trials and you see this, like you go back and let's say you see the one on the right, you have progression.
Mm-hmm.
So you see the progression, do you give it a little more shot and see, let's see how if it progresses again?
No.
You stop it right there.
Progression's progression, so you stop it right there, unless you, again, unless you think, well, you know, in this case, so say someone progresses by 20%, but they have a lot of other sites. These are just the spots that I picked out to measure. But say they have a lot of other disease, or they have a lot of bone lesions, which we can't measure, so that's another story. We don't consider those measurable unless there's a big, like, soft tissue or tumor component of it. So then, in that case, I would always have a study in this cancer where I would say, well, this patient is clearly benefiting from this drug, even though my measurements have increased by 20%. Let's treat longer and check the next imaging. This is, of course, as long as the patient's not having bad side effects from the drug, because you don't want to continue a drug that's not technically working if they're suffering from the side effects. Yes. Oh, sorry. Go ahead.
I was just asking this, so is it fair to say that if you guys as physicians have kind of a good cushion to make the call, it's not just strictly this is what the protocol is for the trial, like you have to do this, you guys can make a decision and say.
It depends how so let me ask that question because they're recording this. So the way it works is if the trial is written very strictly, progression means you go off study, then that's it, you go off study. If the trial is written the way I usually write them, which is you have progression, but if it, in the opinion of the investigator, the patient is still receiving benefit from the treatment, then I will allow the patients to stay on study. So it's different in different places. And I would say, you know, this might be a generalization, but usually for the big trials, you know, that are run by pharmaceutical companies, they don't usually have as much cushion there. Sometimes they'll let you stay on the drug, but then they sort of remove you they'll call you progression and leave you on the drug. Yes.
Is there any margin of error when you're doing your measurement? In other words, are you reading something that's scanned differently by a different person or a certain angle might produce a different number that skews this response?
Yeah, it can, and that's why we really try hard to pick that. I mean, there's this whole publication about these criteria, and that's why you try to pick representative lesions. And if it's close, you know, it could just be the way you measure it, and it could just be the slice. But what you really try to do is find the longest diameter and do it that way. And so, I mean, yeah, but there can be error, but usually the measurements, usually the areas that we're measuring are big enough that it's not gonna make a difference. Yes?
How do you know that it wouldn't have progressed more without the drug?
We don't know. So
Maybe it did help them.
exactly. So we don't know, and that's the problem. I mean, and that's what's, you know, with clinical trials, when you don't have a placebo, when you're just most of these trials with the new drugs. So, you know, I have a study with the drug ponatinib, and we have no idea if this works in medullary thyroid cancer patients. So we just are trying to measure the response and see if we have people respond to it. And if we don't, then that's that. Then the drug won't go into any further development for the cancer. And then, you know, once it's approved or once you move forward, then you can compare it to placebo or compare it to vandetanib. But yeah, I mean, you're just trying to see if there's any sort of response. Furthermore, you know, we don't even know if these drugs, maybe there is a response, but maybe in the end they make the cancer grow faster, or they cause other side effects that are worse than the cancer was in the first place. So that's the problem that we have in all cancers and all clinical trials. So now that I've explained or tried to clarify the way we look at these studies and how these drugs get approved, I'll just show one of the main slides from the vandetanib study. And you all probably know that vandetanib is a small molecule that blocks the Ret protein. And that was the reason that it was tried for medullary thyroid cancer. And it also blocks some of those other signals on the outsides of the cells that cause growth and spread of cancer, VEGF receptor and EGFR. And so this was FDA approved for progressive or symptomatic advanced or metastatic medullary thyroid cancer in April of 2011. There was a 45% PR, so 45% of those patients had confirmed 30% or more shrinkage. But patients have remained on the drug for as long as 2 to 6 years or even more. I follow a patient who was on one of the original MEN2 studies of this drug, so she's been on it since 2006, I think, and she still has stable disease. So, you know, that's where you get to the important part. You know, how long can these people actually stay on the drug without having bad side effects and without the cancer growing? Yes?
7 years.
Yay! I love hearing that. That's so great. I know there are lots of you out there. And so let's see. So at the time, at progression, there was no approved effective therapy. So people were able to remain on the study even if their cancer progressed. And they didn't really have enough tissue to complete the molecular studies the way I would have wanted them to, and they found that there were both Ret mutation positive and Ret mutation negative patients who responded. And then, you look at, say, the MEN2 studies, the hereditary study, where we know everybody had a mutation, and the response rate was lower than it was in the large trial with the sporadic patients involved. So there's definitely something else going on there. And they didn't look at the MEN2 patients' tumors because it could be that they had more than one mutation. So, we know that the MEN2 is caused by Ret mutations, but we don't know what's going on in the actual tumors. If when people get treated or when the disease spreads, if there's more than one mutation there. And the progression-free survival, the median progression-free survival wasn't reached, mostly because there are some people who, respond or stay stable for years and years and years. And then in the placebo arm, so the patients who got placebo, the progression was 19 months, which is, a really long time. But if any of you remember when this trial opened, this was really the first time that there was anything for it. And AstraZeneca, the company, didn't make progression mandated because, you just couldn't do that at that time. People were just chomping at the bit to get something to use for this cancer, and accrual been completed in just a matter of a few months, or 4, 5, 6 months. So some of these people had a lot of disease, and we don't know if they were progressing or not. I would say at least half of them did have definite progression at the time, but so that's why the placebo arm, the progression-free survival, so the amount of time they went without their cancer growing was about 19 months. Was there a question? Yeah. Sure.
Have you guys reached the point where you've gotten a little bit more information to know when you reach, let's just say, calcitonin of 2,000, 5,000, I would say, that this is really not going to be as effective, kind of already too high up in the ladder?
No, absolutely not. So the question is do we know if there's a certain amount of disease on the CAT scan or a calcitonin level where the drugs don't work? Do we know this? And the answer is no. There have been patients with, a small amount of disease. I have one patient, he never had a lot of disease. He just had a 2-centimeter spot, an inch basically on his liver. He's been stable for years on vandetanib. And then I have patients who had just neck full, chipmunk cheeks full of cancer and had dramatic responses. So it doesn't matter what the tumor burden is yet. And the other thing is we don't know if taking it so I'll tell you, in other cancers, what you do is you do the studies for these drugs in the metastatic setting, so when patients are no longer curable, and then you see if the drug works. And then the next step is to give it in the adjuvant setting, which means right after surgery in people who are high risk, to see if you can improve the chances of cure. And we haven't done that yet. So, it could be that eventually we treat people who don't have any disease there. Eventually, I think we'll get there. Any other questions? Oh, sure.
What happens if they stop taking it, and they had success, and then they stop taking it? Is it permanent regression, or?
So what happens if they stop taking it and they had success, and does the cancer, does it stay smaller? Is that the question? Yeah. No. So it's not permanent. So once you stop taking it, you would expect that the effects will not be there for long. It does have a really long half-life, though, of over a month. So you could still have it on board for a month after you stop taking it. Yes, in the back. Sorry, you're next. Yes.
Do you screen that someone with vandetanib must
No. So only about half of patients overall will have that 918 mutation. And in the trial of the vandatinib in both, we know that patients who have 918, some respond and some don't, or some respond and then progress. We don't know what the difference is. So it could be, you could have, say, patients without 918 may have only stable disease and no response, but their stable disease lasts longer. Or, we just don't know really. But if you look at the other trials, at the hereditary trial, patients with 918 germline, so every cell in their body, not all of them responded. But some have been on it for a really long time. So it just sort of depends. But at this point, we don't have enough information to say that 918 is a reason to take or not to take any drug. We're trying to figure that out. There just isn't enough data yet, in my opinion, to make a responsible conclusion about it. Yes?
I was taking vandatinib and I had horrendous side effects. And after a few months, I was taken off of the vandatinib, and the side effects continued for quite a while.
Yeah, that can happen. It depends on the individual's metabolism, but the drug does stay in your system for quite a while. And, sometimes it just depends on what the side effect was and, if it was something that could last longer. I'm not sure.
I had horrible rash,
Oh, yeah.
and that continued for a few months after I took it. I also had diarrhea, and it was going on forever.
Yeah. The diarrhea, so obviously this drug can cause rash and diarrhea. And the rashes are weird. We don't really quite understand how these drugs affect the skin. We do know that if you wear sunscreen that the chances of having the rash are lower, but I've seen severe pigment changes requiring laser therapy. It's just...
Wiped out my fingernails.
Yeah, so, and it just different people seem to have different side effects. The diarrhea is always tricky because it's a symptom of the cancer. So you don't know if the diarrhea is still there because the cancer's grown or if the diarrhea is from the drug. Diarrhea is tricky. Constipation is tricky too. Yes.
Yeah, my frequent bathroom needs got less frequent once I started on preventative.
Yeah, I don't know if for others of you who have been on it, but yes, and some people who had really severe diarrhea. I don't know if I've told this story before, but I had a patient when I was in Oregon who was from Hawaii, and he was an MEN2B patient. So he obviously had the 918 mutation, and he had such severe diarrhea that he couldn't go anywhere, basically. He was hospitalized multiple times for dehydration. I'm not really sure why they weren't giving him better treatment for the diarrhea, but that's another story. But his was so severe. So luckily I was able to get him enrolled on the vandatinib trial, and he would come from Honolulu to Portland. And I remember after he was on the drug for a couple of months, maybe 4 or 5 months, I said, well, how are you feeling? Is your urination normal? And he said, no, I'm peeing all the time. And I said, well, what do you mean? And he said, well, every time I drink a lot of fluids, I pee. And I said, well, guess what? That's normal. But I don't think he remembered not having such severe dehydration and diarrhea that he had never, urinated like a normal person. So I can't even tell you, that's why, we do this, is because that was one of the best things I'd ever heard. I just was so happy that, we made such a difference in his life. He was in a wheelchair and just, and he was a young guy, and he just, he got so much better. And it was very rewarding. Any other diarrhea stories? Okay. So now I'll talk about Kabezanito, talk about diarrhea. So I moved to the NIH about 6 months or a year into this trial. So I only was able to treat a few patients on this drug. I had one patient, well, we think it was the drug because it was a placebo study, so it was Kabezanito versus placebo. I had one patient who he had a big neck tumor and it just melted away in a matter of weeks. I mean, 1 week, 2 weeks. But then he had some other side effects. And then I had another patient who just had severe diarrhea, and we assumed that she was on the drug, but she actually couldn't stay on it. But that was before we really knew a lot about this drug. This was in the beginning of that study. And so as you know, this drug got approved. The median progression-free survival, so the amount of time most patients went without progressing was 11 months in the Kabezanito arm and 4 months in the placebo arm. And that's because in this study, they made the enrollment criteria, people had to have progressed within, I think it was 12 to 14 months prior to enrollment. So, and progressed again, meaning by those criteria, we use those, 30% or more. So they had to have scans to look and see. So that was another challenging part about enrolling the patients, is to have scans that far back so you could actually show that they had progressed. And then in this one, they had a partial response rate of 27%. So again, might not sound all that impressive, but really what matters is how long people were able to stay on the drug and control the cancer. And this is just a separation of these curves here. The blue is progression-free survival for placebo, and the red is for drug. So just the length of time, obviously, when there's a separation between the two curves, if you ever see these, that's good. The farther apart, the better. There was a study at our main cancer conference for oncologists in Chicago called ASCO for a drug, lenvatinib, for papillary thyroid cancer or differentiated thyroid cancer. And the curves were the farthest apart I'd ever seen. So we're really excited about that drug for that cancer. So when should I start treatment? It's hard to know exactly. Usually you should try to contact someone who's treated a lot of patients with medullary thyroid cancer, sometimes just by email. I talk on the phone to people. I talk on the phone to oncologists, because you'll have someone who is being followed by their endocrinologist, and calcitonin is creeping up, and they don't like that, and and the patient doesn't like it, so they want to do something. But doing something isn't always the best thing, and I would say in most cases it's not, because you really need to have evidence that this drug is going to help you, not harm you. And so you can look at the national guidelines. This is the National Comprehensive Cancer Center Network publishes these guidelines, and they say to consider vandetanib or cabozantinib when there's unresectable disease, so surgery is not an option, and it's causing symptoms, or structurally progressive, meaning it might be about to disrupt some sort of important vital structure in your body, like your trachea or your esophagus, or it's causing problems. So not just growing, but growing and causing problems. And they also say, back to someone else's question, that increasing tumor markers in the absence of structural disease progression, meaning in the absence of actually seeing the cancer grow on CAT scans, is not an indication to start those drugs. What time is it? I just want to make sure. Okay. So the American Thyroid Association guidelines are outdated. They're from 2009, but they said that asymptomatic patients with a small volume of metastatic disease that is stable or slowly growing, as determined by anatomic imaging, so CAT scans, sometimes PET scans, or a calcitonin and CEA doubling time of that should be, of over 2 years typically do not require systemic therapy, so they don't require one of these drugs, and the decision to initiate such treatment should be made with the patient only after a thorough discussion. So, they're saying if the calcitonin is doubling really slowly and the disease is growing very slowly, then really you shouldn't start. And I wouldn't even necessarily look at the calcitonin. There's a huge difference between a doubling of a 5,000 to 10,000 calcitonin and a 40 to 80 calcitonin. I mean, they both are doubled, but the difference in the amount of disease is significant. So I wouldn't necessarily look at doubling time unless there's a lot of disease already present that you can see on the CAT scans. Up to date is an expert review and opinion that a lot of physicians look at, and it's written by experts in the field. And so what they say is metastatic tumors that are at least 1 to 2 centimeters, and they're growing by at least 20% per year, or patients with symptoms related to multiple metastatic foci, so multiple areas of the cancer that can't be alleviated with surgery or radiation. So same sort of thing. They're saying it has to be at least 1 to 2 centimeters in several sites that are progressing by our RECIST criteria, or someone who has a lot of cancer. We might not know if it's progressed because they were just diagnosed. So, sometimes people get diagnosed with metastatic disease, and we don't know how long it's taken to progress, but we do know they're having bad diarrhea, so they better get started on something. And then individual considerations. So you always have to discuss the risks and benefits with everyone. And the rule as a physician is to first do no harm. So you can't force your physician to prescribe something for you that they think is really not going to benefit you. But I know that we all hopefully take into consideration the wishes of our patients. And if someone is just having unbearable anxiety because they can't stand not being treated, and I think, okay, well, it's sort of on the border, I probably wouldn't take the drug if it were me, but this person really is wanting to do this, sometimes we'll prescribe the drug. And it's important to note that at this point, we haven't shown that any of these treatments make people live longer. So, we know that they can prevent progression from the cancer, and we do know that they can make the cancer shrink, but in the end, are they making anyone live longer? If you look at the survival curves from both of those studies so far, they're identical. So placebo, vandetanib, people live just as long on average. But that takes into account the people who weren't progressing and the people who were progressing. So we just don't know yet. And that's why you really need to wait until you need to be treated to take these drugs, because they do have side effects. So then, now that we have two, the question is which drug should I be treated with? And as you know, probably, they haven't been tested head-to-head, and you have to weigh the potential side effects with the individual patient's symptoms or lack of symptoms. Sometimes it's doctor preference, which drug the doctor has more experience with. And so this is important. So cabozantinib causes more neuropathy typically than vandetanib. Or it can cause hand-foot syndrome. So you can have peeling of the skin on your hands and feet. Well, if you're a professional violinist or some sort of musician, that's probably not the best drug to start with, because we know that that's a risk for you. So probably you should start with vandetanib. But then there are other considerations, like if you have an abnormality on your EKG, and it's called, prolonged QT, and it puts you at risk of having a heart complication from a vandetanib, then you should probably start with cabozantinib. Diarrhea, it's sort of a toss-up. I don't know which is better or worse, but we have to look at those individual, side effects. There's some suggestion that cabozantinib may be better for bone metastases, but That's in other cancers, and we just don't know yet. And I've seen it go both ways in patients. And we've actually been sometimes treating people on vandetanib, then cabozantinib, and then going back to vandetanib because the cabozantinib was controlling the bone lesions, but the vandetanib was doing better with the liver lesions. And so we're trying these sorts of things because when there's nothing, better to try, and we know something worked for at least part of the cancer, it's worth trying. This is a list of all of the side effects of cabozantinib. I like to point these out, though, just because even though this is a huge list, there are a lot of side effects in placebo as well. So 33% of patients in placebo had diarrhea, 63% in the cabozantinib had diarrhea. So, you have to kind of think about that as well. There are always going to be baseline side effects, and there was just, so the sorafenib study for papillary thyroid cancer, was it sorafenib or was it lenvatinib? I can't remember. One of them, they looked at the side effects in the treatment arm and the side effects in the placebo arm, just overall, who had side effects. 86 or 87% of patients in the placebo arm had a side effect. So they're taking everything that a patient complains of. And obviously some of these are going to be more serious than others. And I made this table, I think, for last year's talk, just to kind of look at the overall percentages and then the percentages of more severe. So here we have sort of the most common diarrhea. The overall percentage was about 56% in vandetanib, 63% in cabozantinib. Maybe there were fewer severe cases in the vandetanib and a little bit more in the cabozantinib. Really, this is sort of blasphemy in oncology land because you're never supposed to compare side effects from studies that aren't together, but this is all we have, so we have to try. Nausea is about the same. Rash is obviously worse in vandetanib, we knew that. High blood pressure, about the same in both. Fatigue, maybe a little worse in cabozantinib, but again, it's hard to know because people have fatigue at baseline, and those patients had been progressing, so they might have had more advanced disease. Acne, obviously, that's the vandetanib problem. And then weakness, weight loss. Weight loss was more significant in cabozantinib, but again, these patients had progression and they had more aggressive disease, and the patients on the placebo arm were progressing in 4 months, which is pretty fast for medullary thyroid cancer. And then the big one for vandetanib is this QT interval on the EKG. The QT interval is basically just your heart electric wave, and if it's short, that's okay. It can't be too short. But if it's long, then that can cause a fatal arrhythmia. So that's bad. And one of the things that vandetanib does in some people is prolong that QT interval. And that puts people at risk of developing a fatal arrhythmia where, the heart, everyone's seen it on TV. This, when you have this torsade, which is when the interval gets too long, it can go and then sudden death is basically the main complication. So, if you're on this drug, you have to have an EKG before you start. Everything has to look good. You have to get monitored. Yes?
Do those potential heart problems linger even if you go off the drug?
No. No, if you had it before it started, then it'll stay there. And actually, some other drugs can cause it too. So you have to look at the drug list and see if any of the other drugs that people are taking can cause it. But no, it prolongs that interval, and then it can prolong that interval, and then once you stop the drug, it goes away. And in fact, I had one patient who was on it. It made his interval too long. Sometimes it can just be because their magnesium was too low in the blood or potassium was too low in the blood, and the interval was long. We stopped the drug, restarted it at a lower dose, and then he was fine. So you just have to watch it and be careful. And actually, in the vandetanib trial, there were no people who had sudden death in the big trial. Later on, I think there were 2, and I don't know that torsade was ever that fatal arrhythmia was confirmed in any of them, but I know that in the lung cancer trial, they did see, with the same drug, they did see it. So you just have to be careful.
Yeah, one side effect I am experiencing is deposits on the cornea.
Oh, yeah. Mm-hmm.
Look at that as well.
Yeah, so, that's pretty rare, and I think that I only have one patient who's had that as well, but again, that's another potential. Deposits on the cornea. So it's sort of like skin changes on the inside of the eye. I had one patient who was a farmer, and she actually got freckles and inside her eyes, inside her eyelids, because she wasn't wearing protective eyewear. She would wear her sunscreen and her hat, but she was getting the glare. So, everything looked fine except inside her eyes. So there are all kinds of things.
So sunglasses are recommended?
Yeah, I would try. Yeah, especially when you're out in the sun for a prolonged period of time, in addition to the sunscreen. Yeah, and I don't think that most people would have thought about it if they hadn't actually seen, those pigment changes like I did. I don't know if it'll help with the corneal deposits, but it's also good to prevent wrinkles. So, yes, go ahead.
Is there any truth that the patients with Ret M918 Kabezanito live?
No, I don't think, no, so there isn't. So the question is there any evidence that cabozantinib is more effective in patients with the 918 mutation than vandetanib is? And really, in order to say that, you have to treat patients head to head, make sure you know what the mutation is in everybody's tumor, and then see what has the higher response rate. I have seen lots of patients who have progressed on both. I have seen patients, because I'm genotyping, I'm looking for those mutations in patients right now at the NCI, and it's been both. Some have stayed on cabozantinib for a less amount of time who have 918 than they were on vandetanib. And some patients with 918 I've seen just blow through both of them. We just don't know. So that's why I hesitate to, translate what one study shows into, a global recommendation for which treatment to take based on the presence of a mutation or not. Because the other thing you have to remember is that that's just one spot, and there's a mutation there, and we don't know if it holds true for the other tumors in the rest of your body. And then here I just have some of the other complications from cabozantinib that really weren't seen in vandetanib. That hand-foot syndrome, like I was talking about, hair color change, which is interesting. And then they had some fatal hemorrhage and vomiting. So the fatal hemorrhage is obviously what you worry about most, because you don't want to treat someone with a drug that's going to potentially cause them to die. They can get these fistulas, and so you have to just really need to take one of these drugs, because not everybody does well. Most people do, but not everybody. Yes.
I don't want to monopolize too much time because
No.
I think it's fairly rare. I'm on the vandetanib, but also have been diagnosed with Cushing's syndrome. You can talk more a little bit about the Cushing's.
Yeah, Cushing's. So let me see how to explain this. so Cushing. No, it's related to the cancer. So Cushing's syndrome is one of the potential side effects of medullary thyroid cancer, and it's very uncommon. But when we think of medullary thyroid cancer, we think, we know it makes calcitonin, and we know it makes CEA, and usually more calcitonin than CEA, but sometimes not. But some of the cancers can make this other hormone called ACTH, which is usually made by your pituitary gland. And that stimulates the adrenal glands to make cortisol, which is basically steroid. So people who have Cushing's syndrome can develop buffalo hump and abdominal striae and other symptoms related to Cushing's disease or Cushing's syndrome. Cushing's disease is when you have the abnormal pituitary gland. Cushing's syndrome is when something else causes those same symptoms. And so it's very uncommon, but it's one of the things that you can see with medullary thyroid cancer. So hopefully the drug is helping. Good. So which one should you use first? Oh gosh, I have no idea. Patients treated with vandetanib were on the cabozantinib trial, so we know that cabozantinib came later, so 11% of the patients who were on cabozantinib had already been on vandetanib, not vice versa. Vandetanib was approved first, there's more experience, there's no right answer. Some people think, well, if the cancer is progressing, you should start cabozantinib because that was one of the enrollment criteria in the trial, but I don't think that's necessarily true. I mean, I think that you can just pick one based on the physician preference, patient preference, and individual, because we don't have any data that one is better than the other in any way. These are the other drugs that have been tried. So if neither of these work, you can try sorafenib or sunitinib. Nexavar is Sutent. We've been using those in small studies for a long time, and those have similar response rates, and some people will have some stable disease on these drugs. The lenvatinib that was used for differentiated thyroid cancer also had a response rate. That's not FDA approved yet, so it's not going to be available for medullary thyroid cancer patients or anyone. So where do we go from here? There are so many questions to answer. Will these drugs make people live longer? Does it matter if you take them early in the disease versus later? Does it matter what sequence they're given? Can we give them before or after surgery to help improve the chance of cure? Can we combine them with another type of chemotherapy or targeted therapy to improve the symptoms or response? Yes?
Since he was diagnosed, is when all of these drugs have come, these two drugs have become available. Well, you know how all these other cancers, you know, there's chemotherapy for this cancer, that cancer, this cancer, all these things. Like how long does it take before thyroid cancer is like 20 years, 50 years before?
We have lots of.
Because all this is so new and we
Mhm.
don't know so much. How long does it normally, like with research and all that stuff, how many years does it take to like get?
Yeah, it's a good question. So it depends how the studies are done. Sometimes it takes a shorter amount of time. So, and it depends on whether or not you can accrue patients to the studies, because you really need to have participation of patients in order to get the data, to see, what the answers to these questions are. So for breast cancer, for instance, it's so much more common. There's so many more patients. You can get these humongous trials. You can follow huge groups of, nurses for years and years and years and get tons of data. And so it's much easier to move things along. Not that it's easy, but we have more treatment options, obviously, for breast cancer. And then, there's funding involved and things like that. And so it's hard to know. The rate of change, however, since I started studying medullary thyroid cancer in general, has been more than I've seen in any other cancer. So, yeah, this went really quickly. And it was basically just the discovery that some of these drugs were inhibiting Ret, blocking Ret, and before that, no one was really looking. So, we started noticing that, we can target cancers with these drugs. Well, do these drugs work for Ret? Maybe, and then we start looking at that, and then we tested in mice. Oh, yeah, it does make the cancer shrink in mice. Then you have to try to find people, and Dr. Wells fought really hard with AstraZeneca to get them to let him use the drug for the MEN2 patients. He begged and begged and begged, and they did, and now look at what we have. So I don't know how long it's going to take to get more, but compared to what we had, it's pretty amazing. Yeah, I mean, just Yeah, just so when that vandetanib trial opened, the large randomized trial in, what was that, 2007, I think, there was nothing for patients even to be treated with. We were sort of treating some people with sorafenib or maybe sunitinib off-label, but that's why the trial filled up so quickly. And then the cabozantinib filled up quickly. So we're lucky that we got these drugs approved so quickly, because that is actually pretty fast. And we're lucky that both of them worked. What time is it? How much time? Okay. Okay. So the last part is just to tell you what we have happening at the National Cancer Institute. So we're combining vandetanib with a large panel of other drugs and to look in cells to see, if combinations might work better. So that's going to happen, hopefully. We have a CEA vaccine trial that is going on now. So even though not everybody's medullary thyroid cancer makes CEA, they're all coded with CEA. And so the goal for this is to have a very non-toxic vaccine for people who just have a little bit of medullary thyroid cancer or who just have, circulating levels of calcitonin, and I can pretend that one tiny lymph node in their neck is medullary thyroid cancer. And then we can put them on the trial and see if we can slow down the progression of the calcitonin growth or calcitonin increase. So that's what that trial is. And we're getting a lot of patients for that, but I don't have any data for you yet. And then I mentioned I have this drug ponatinib in medullary thyroid cancer. So this is just the CEA vaccine. So the CEA is a tumor marker that can be measured in the blood in patients, and basically, I won't go into how you make all these tumor vaccines, but it's a yeast vaccine, and it's safe and heat killed. So they already did the safety studies. We already did the safety studies at the NIH, and it's very safe. Minimal side effects, maybe some itching, burning at the sites of injection. There are 4 sites. The only people who have reactions would be people who are allergic to brewer's yeast or baker's yeast, and that's pretty much no one. So, but we always test people to see if they have a yeast allergy. And the hope with the vaccine is that it'll prevent progression long down the road. We aren't really expecting to see dramatic decreases in calcitonin, but we're hoping that we slow the rate of growth and then maybe this lasts longer down the road, because that's what tumor vaccines are showing in prostate cancer. And a lot of the work in the prostate cancer vaccines is done at the NCI by this group I'm collaborating with. These are the eligibility criteria. I think everybody is going to have access to these slides, which is why I put all this information on here. This isn't necessary to discuss right now, but obviously you have to be in good shape. You have to be able to come to the NIH. All of the transportation after you're enrolled in a study is provided by the NIH. And then all of the drugs and the treatment is provided by the NIH. So it's a good place to be on a study. The only problem is you have to come to Bethesda. Yes?
Can you do this trial if, let's say, you decided to do an embolization? Like if you're doing that for liver and you want to do this, can you do them together?
So that's a good question. You can't really do it together, but you could do it after, most likely.
I'm saying, like, let's say a month ago I did the embolization, and then next month I want to come to you guys.
Yeah, you could. And it just depends on, how much cancer you have. If it's someone who I would look at and say, oh, this person probably should get vandetanib or cabozantinib, then you're not really eligible for the study. But if you just are doing embolization to one spot because you're trying to get rid of it, then yeah, you could definitely. I think the prior vandetanib and cabozantinib are, and I don't know if, I can't remember if we've excluded all chemotherapy, because we don't ever see anyone who's gotten chemotherapy, but chemoembolization is not chemotherapy. So I think that would be fine, but no prior vandetanib or cabozantinib. Yes?
Before I had my last surgery, an overzealous oncologist put me on Cabo for 2 weeks. Does that give me out?
Well, I don't know. It technically does. Technically does. But you can always contact. I have my cards up here. You can always contact me and send me all your stuff, and I can look over everything and let you know. Yeah, anyone can call me whenever they want. Yes.
Why is you don't want treatments?
That's just the way the study is designed. So it has to do with the immunologic response and the prior treatment with the kinase inhibitors.
Are there any other research programs now using the immune system?
Yeah. So you mean like?
In other words, using the body's immune system to
Yeah.
identify and go after.
Yeah, so that's what a tumor vaccine is. So you basically put a little piece of CEA and you get these yeast cells to recognize it, you put it in a little yeast cell. I'm explaining this horribly, but for the sake of time, and then you inject it into the body, and it won't do the body any harm, but you're hoping that the immune system says, this is a foreign body, I don't like this. And then they make all of these helper cells and T cells that will then, if they see CEA, go after it. And we know CEA's, yeah. So we know there's CEA obviously on the thyroid tumors, so the hope is that then they would go after it. That's just, in this study, there is a, just to tell you, there is not a placebo arm, but there's a sort of an internal control. So when you enroll in the study, half the people go on vaccine immediately, half will be observed for 6 months and then get the vaccine for a year. But everybody ends up getting the vaccine, assuming your cancer doesn't grow too much and you need some other treatment. And then this study is one for the advanced patients who have been treated with both cabozantinib and vandatinib. And I'm looking at the responses in RET positive and RET negative tumors. So if we don't know the tumor type, if we don't know whether or not there's a mutation, we test all of them for mutations and see. And this is just a table to show you that work that's been done that showed that ponatinib actually was a stronger blocker of the RET protein than any of the other drugs that we've used before. And this is a mouse study done by the same person who did the mice study in the original vandatinib trials. And this is just, and again, these are mice with medullary thyroid tumors, but these are mice who got no treatment, and their tumors went, whoop, and these are, the lower one is the mice who got treated, and as you can see, their tumors went away. So this was better than what Dr. Santoro saw with vandatinib, so we're very, very hopeful. Yes?
There's a lot of information out there right now, or articles being written on what they call the remarkable responders. People that had a really remarkable response, like to Cabo or Benitinib, then later on that remarkable responder hit a resistance level. And they're looking at the actual pathology of the tumors as to when you started or prior to a drug, the pathology said this, and then after there was resistance, pathology said that. My understanding is in medullary, the ponatinib trial was the only one that was actually doing something along those lines to actually look at the tumor response as it goes.
That's true.
And taking the biopsies to see and chart what the difference was.
Yeah.
Do you think that the FDA will go back to the original design at any time to allow people that have never taken the Cabo or the Benitinib to then go back to ponatinib? Because that's the way it was originally designed until the FDA said no.
Yeah, so there were some unfortunate complications with this clinical trial. This drug is approved for resistant chronic myelogenous leukemia. And and other types of blood cancers, but there was a high rate of arterial events, meaning there were some strokes and blood clots, and so the FDA put it on hold right after I opened it, and then let me reopen it. But they said now we need patients who have progressed on vandetanib and cabozantinib, or who didn't tolerate both. So. Yeah, so that's been the problem that we've had, is trying to get people on the trial because they've had to be treated with both, and it's also the sickest. So what my hope is that we have a good responder, and then I go back to the FDA. But I don't think the FDA is going to budge at all unless the complication rates in the CML go down with the lower dose of 30 milligrams that I had to reduce it to, or unless I start seeing some responders and then getting more patients on the study.
What about the data on the changing, the changing tissue, the changing biology? Because that seems to be where they're going with all the other cancers at this point.
Yeah, so we're doing pre-treatment and post-treatment biopsies. Now, I haven't had very many patients, so I haven't had anyone respond and then progress. I had a patient with stable disease, and then I had a patient who just progressed. So, we don't have any information about that yet. And that's all going to be, exploratory and in the future. But at least we'll be able to see whether or not it makes a difference up front if you have a Ret mutation or don't have a Ret mutation. So it looks like other people are coming in. So if you have any other questions, I'll just put my cards up here. And, and I had brochures that I forgot to bring down. But I'll put my cards up here, and you can email me or call me or whatever.